Hello, and welcome to the ROSA Worldwide Webinar Series. My name is Mike Reed. I'm the Chief Scientist at ROSA, and I thank you all for joining. Please check the ROSA website for upcoming webinars. During today's talk, if you'd like to ask questions of the speaker, you can enter those questions by clicking at the Q&A button at the bottom of your screen and entering your questions. We'll ask the speaker questions at the end of her talk. Our speaker today is Heather Collis. She is a fellow at the AstraZeneca Postdoc Programme, and she's presenting to our audience as a part of our early career webinar series. Heather joined AstraZeneca in January 2023 and is currently working from the Gothenburg site in Sweden. She obtained her PhD in mathematics from the University of Nottingham, where her work focused on understanding the dynamics of hormone transport in the vasculature of young plants. At AstraZeneca, her focus is using machine learning to model disease progression of metabolic dysfunction-associated steatotic liver disease. Thank you, everyone, and welcome, Heather. We're looking forward to your talk today.
Thank you very much, Mike, for that nice introduction. As you said, my name's Heather, and I'm a postdoc fellow at AstraZeneca in Sweden. And today I'm going to talk to you about some of my work looking at proteomics data in different cohorts of patients with MASLD, which is metabolic dysfunction-associated steatotic liver disease, but I will probably be using the acronym for the rest of this presentation. So there's two different cohorts that I want to highlight that I will be talking about throughout this presentation. The first is a clinical cohort, and we use this cohort to develop a random forest pipeline to look at fibrosis classification in MASLD. And the second is a subpopulation of the UK Biobank that we use to assess the prognostic potential of the results of the random forest pipeline. And this was, a subpopulation of the UK Biobank. So first of all, what is metabolic dysfunction-associated steatotic liver disease? Well, it was formerly called non-alcoholic fatty liver disease, so you might know it by its former name, but it's a silent disease and slow progressing disease with a high unmet medical need. It's initially characterized by an accumulation of fat in the liver, and as the disease progresses, patients often develop inflammation, liver injury, and scarring of the liver, which is called fibrosis. And this eventually proceeds to cirrhosis of the liver, which is where healthy liver tissue has been replaced by scar tissue. It's estimated to affect up to 30% of the adult population worldwide. And currently there's only one approved treatment, which is Rezdiffra, which was approved fairly recently. And the disease progression and the quantification of MASLD is quite difficult and is currently performed by a liver biopsy. So liver biopsies is the gold standard for MASLD diagnosis. However, it has a few drawbacks. It's an invasive procedure, which often can lead to various risks for patients. These can include low-level risks like discomfort, but do include risks of complications up to and including death. Another drawback is there are often long waiting times for liver biopsies to occur. This can lead to up to 6 months between a blood sample being taken and a corresponding liver biopsy being taken. They also suffer from sampling error issues because only a snapshot of the liver is taken. About 1/50,000th of the liver is seen in each liver biopsy sample, so not very much. But as I said, they are currently the gold standard used for assessing MASLD and its associated histological features. So liver biopsies are used to assess fibrosis, which was that liver scarring, steatosis, which is the accumulation of fat in the liver, ballooning, which is associated liver injury, and the inflammation that I spoke about previously. So we focus on fibrosis, and this is because it is currently the only histological feature that has been shown to independently correlate with clinical outcomes in patients with MASLD. So in this figure here, we can see the survival time free of liver transplant for the various fibrosis stages associated with MASLD, with F0 being no fibrosis, F1 being the mildest, and F4 being the most severe. And we can see that comparing the mild fibrosis stages to the advanced fibrosis stages, there's a clear difference in survival free of liver transplant outcomes for these patients. So why are we interested in this? Well, the gold standard of the liver biopsy, as you heard, has a few drawbacks. And as such, a clear aim of the sort of field is to use a non-invasive test to establish which patients have this mild or advanced fibrosis to ensure optimal treatment for patients with MASLD. So currently, clinical guidelines refer to a non-invasive score called the FIB-4 score. The FIB-4 score is comprised of 4 standard clinical biomarkers: age, AST, ALT, and platelet count. And it has 2 thresholds which are used to distinguish mild and advanced fibrosis. A lower threshold, which is used to rule out advanced fibrosis, and a high threshold, which is used to identify patients at high risk of advanced fibrosis. Patients that fall between these 2 thresholds receive no classification and are left as indeterminate. And we can see on the left-hand side here that this FIB-4 index forms part of common clinical practice guidelines. So here's one shown in detail, but it is consistently used throughout various different clinical care guidelines, as sort of shown by these figures here. So we want a simple and clear assessment for use for referring patients to the correct treatment. As fibrosis is the is the only histological feature that correlates with clinical outcome, it is fibrosis that is looked to be assessed with those non-invasive tests. So the clinical cohort that we studied is comprised of 87 patients with biopsy-confirmed MASLD. We had over 1,000 biomarkers for these patients. This included over 900 plasma proteomic biomarkers from the Olink proteomic platform and 71 standard clinical biomarkers. In this analysis, we retained biomarkers which had less than 20% of the data missing. And we analysed this using random forests. So what are random forests? Random forests are a machine learning algorithm which is comprised of an ensemble of decision trees. So really, we should start with the question of what are decision trees? Decision trees can be thought of as a string of questions designed to split a group into homogeneous subgroups. We could obviously ask an infinite number of questions and get a perfect classification, but that would be overfitting and something that we like to avoid. And this is where random forests come in. Random forests use 2 key features to prohibit overfitting in decision trees. So they use bootstrap aggregation or bagging, which is where a subset of the data set is taken with replacement, and that is used to train an individual decision tree in the random forest. And feature randomness, which is where the sort of questions that are posed in each decision tree, only a subset of the biomarkers available in the data set are used at each split to find an optimal split. So overall, these reduce the amount of correlation between individual decision trees in a random forest. And this allows, when a majority vote is taken across the whole random forest, improved model predictions. So random forests work well with all sorts of data types, and they can handle linear and non-linear relationships, as well as being robust to outliers. But they do, however, lose some interpretability. As I said, the decision trees can be quite easily individually thought of as a string of questions, but it is not so clear how we can interpret random forests in the same way. They can be computationally expensive, and they struggle to handle missing data in predictive features. Another strength of random forests is that they implicitly perform feature selection, which is the process of selecting the most consistently useful features in model construction. Commonly in machine learning, we are looking to find what is called the minimal optimal set of features to produce a classification. And so we want to reduce correlation between the biomarkers in that set because we don't want to have redundant information. However, we chose to use a feature selection algorithm called the Baruta feature selection algorithm. This selects the all relevant feature set, and this differs from the minimal optimal in the sense that some of the features may be highly correlated still and may contain redundant information. The benefit of the all relevant data set is that if there is little understanding of a disease's nature, the all relevant feature selection process pulls out features that could be potentially indicative of some unknown pathway. And this was a feature selection technique that was initially developed with omics data sets in mind. So a little bit more about the Baruta algorithm and how it works. So if we have a data set, I'm showing just a small one here, the first thing that happens is the data set is duplicated, and then each of the duplicated features is randomly permuted to remove any correlation with the outcome we are trying to predict. So in our case, all correlation is removed from the fibrosis stage. These two data sets are then appended together, and then random forest simulations are performed on this full extended data set. At the end of your random forest simulation, you look for which of these features of the permuted features, which are called shadow variables, you look for which of these has the maximum feature importance. And because we have removed the correlation with the outcome that we're trying to predict, this feature importance has come about from random chance. And so we then assess the actual features of our data set against this maximum shadow variable come about from random chance to see which ones have an importance higher than it and which ones have an importance lower than it. For features that have an importance higher than it, we assign them a hit, and then we can use a binomial distribution over these iterations to say whether a feature is coming out significantly more often higher than the maximum shadow variable or significantly more often lower than the maximum shadow variable. And this allows us to reject features in the left-hand tile as unimportant and accept features in the right-hand tile as important. You repeat this process over multiple iterations, and hopefully you assign all features either as important or non-important. Often is the case that you will be left with a handful that cannot be assigned even in the process of the full iteration. What you do with them is a bit open for interpretation. We proceeded with caution, so any features that were left unclassified, we retained in our importance subset so that we were looking at any feature that had potential to be of use to us. And so what did we find with our pipeline on our data set? The random forest pipeline output 23 biomarkers as important. So as you can see here, we had 3 that weren't quite above the maximum shadow variable, but as I said, we retained just in case for comprehensive analysis. And so this sort of selection of features could be used to look as like a disease signature pattern. But actually for us, we were quite intrigued by the fact that we had one feature jumping out as significantly more important even than all the rest of the features that got assigned importance. So using this, we decided to investigate whether our top ranked feature, which is epidermal growth factor like 7 or EGFL7, could be used as a single biomarker to assess mild versus advanced fibrosis. So we used Uden's index, balancing sensitivity and specificity to establish a single threshold for EGFL7 to classify patients with MASLD as either mild or advanced. And on the right-hand side, you can see the results of that performance. So we can see, comparing to the FIB4 score that I spoke about previously, that we have a comparable accuracy, comparable sensitivities and specificities, and pretty consistent results across all model metrics. However, because we could do this using a single threshold, we were actually able to classify 100% of the patients in our cohort as mild or advanced fibrosis, whereas the FIB4 score with those 2 thresholds left 43% of our patient cohort unclassified. So we were really pleased with this, and we feel like this was a strong indication of EGFL7 having relevance to metabolic dysfunction-associated steatotic liver disease. So really, we should talk about what EGFL7 is. As I said, it stands for epidermal growth factor like 7, and it's an angiogenic signaling factor, almost exclusively expressed in endothelial cells. It's been associated with blood vessel development and angiogenesis and can be seen in chronic inflammation. And probably most crucially for our analysis, its expression is elevated in hepatocellular carcinomas, which is one of the long-term liver-related outcomes of if patients with MASLD are left untreated. And it promotes the metastasis of HCC. But there's nothing linking it directly to metabolic dysfunction-associated steatotic liver disease. However, angiogenesis has been linked to fatty liver disease. Angiogenesis has been shown to be significantly increased in patients with NASH, which is an old acronym for metabolic dysfunction-associated steatohepatitis, when compared to healthy tissues. And the degree of angiogenesis has also been shown to correlate with the development of fibrosis. So overall, we felt that this information and the fact that we had pulled this out from a MASLD cohort was a promising step in highlighting that EGFR7 might be a potential new biomarker for patients with MASLD. We did, however, want to validate these findings, particularly because we used quite a small cohort for machine learning techniques to start with. And this is where we turn to the UK Biobank. So the UK Biobank is a prospective cohort study of nearly 500,000, or over 500,000, I should say, participants from the UK. Baseline characteristics and blood biochemistry were collected for nearly all of these participants. They were followed through their healthcare records. So there is a death register with cause of death standardized using the ICD-10 codes. But useful for us in particular is there was also Olink proteomic data available for over 54,000 of these participants, as well as diagnosis records, so hospital diagnosis codes, which included 2 that can be used to pull out MASLD patients. Now, we started with quite a large number, but when you draw this down looking for a subpopulation with MASLD and with the Olink data available, we were left with 949 participants with a MASLD diagnosis code, and that had the Olink data available for us to look at EGFR7 in this population. And with this population, we wanted to answer the key question, which is EGFR7 prognostic for MASLD patients in the UK Biobank? So we began by just exploring EGFR7 in the UK Biobank quite broadly. So we just took the full range of EGFR7 values and split it by quartiles and looked at survival probability for all-cause mortality. And already we saw some promising results that we can see a split between the lower 2 quartiles and the top 2 quartiles in terms of survival probability with all-cause mortality. But we did want to dig into this a bit more specifically. So using that threshold we previously established for EGFR7, we used that to look at the survival probability from all-cause mortality for all patients. And we found that above a threshold of 0.2, we found that patients are significantly more likely to die from all-cause mortality. And this is in that MASLD subpopulation we extracted from the UK Biobank. It's quite interesting. I mentioned that MASLD is a slow progressing disease, and you can see for the first 5 years, there's quite a strong overlap between these 2 patient cohorts before the split begins to be seen. And this is one of the things that makes assessing patients for treatment quite difficult in MASLD, because it is so slow progressing over those initial 5 years. It is difficult to distinguish these patients. But as you can see over time, it is quite important for us to be able to draw out which of these patient cohorts, where these patients fall in these 2 cohorts, because it does have an effect on long-term survival probability. So a good question to ask now is, are EGFR7 survival results really reflective of EGFR7's prognostic potential? Or is this being influenced by some confounding variable? Because we're using a real-world data set now with the UK Biobank, there's always the chance for confounding variables to come into play. So we used hazard ratios, a Cox proportional hazard model, to look at the hazard ratios. And in our crude model with just the EGFR7, we found that EGFR7 levels were had a hazard ratio of 2. And then we decided to perform this model again, but adjusted for some key characteristics. So adjusted for baseline age, and then these are all standard features that might confound with MASLD disease. And what we found is, yes, the hazard ratio reduced slightly to 1.51, but we did, however, see, even when assessing for a decent number of confounding variables, we did still have a significant p-value for EGFR7 influencing survival outcomes for patients with MASLD. Our next step was to look at a matched control population. So here, again, because the diagnosis of MASLD is so complicated, a lot of these patients also have comorbidities. We wanted to try and tease out whether EGFR7 was specifically linked with MASLD or whether this could be tied to some other comorbidities. So in this case, we looked for patients without any MASLD diagnosis code in the UK Biobank. We took 2 threshold values, so an MRI PDFF, which is an ultrasound technique for the liver, of less than 5%, and this is the threshold used in the literature for saying that there's no steatosis in the liver, there's no fatty liver. And we looked for patients with a FIB4 score below that lower threshold as an extra reduction of the chance of these patients having MASLD or liver fibrosis. And then we matched them on key characteristics of common comorbidities associated with MASLD. And so when we matched on these and made these restrictions, we found that EGFR7 was not predictive of all-cause mortality in this patient cohort, which was of comparable size to the patient cohort used to make the initial assessment. So again, we found this really quite promising, like we've controlled, and now we're seeing that EGFR7 is no longer predictive. And so that's really teasing out its relationship to MASLD. And finally, we sort of wanted to think about the fact that currently we've only been talking about all-cause mortality. But we also wanted to look at liver-related outcomes in this MASLD population, because obviously this is probably a bigger risk for these patients. Now, this was still a comparable sized population that we managed to draw out. However, there were very limited number of liver-related deaths in the UK Biobank in the data sets constraints we were looking at. So there were only 31 deaths in this whole cohort, and only 2 of them were in the cohort with EGFR7 levels below the threshold value. So these results here are a bit more tentative, a bit more hesitant, but we do see a promising initial result here that EGFR7 above the threshold of 0.12 can be linked to survival probability from liver-related outcomes. So to summarise, we looked with a clinical cohort. We used a machine learning pipeline, which revealed that epidermal growth factor like 7 was a top-ranked biomarker for fibrosis classification. When used with a single value threshold, it outperforms the most widely used non-invasive test for fibrosis classification, which is the FIB4 score. Extending this analysis, we could validate this in the UK Biobank by finding that survival analysis of a MASLD cohort revealed that EGFR7 was prognostic for all-cause mortality. We could see that a matched control population further highlighted this as a biomarker of interest by showing that there was no link to all-cause mortality. And finally, we had the tentative result that there was some promising evidence that this could also be linked to the survival probability for liver-related outcomes in a MASLD subpopulation of the UK Biobank. So with that, I would like to thank everyone I've worked with on this, my collaborators at Linköping University and the University of Ilmenau, as well as my colleagues here at AstraZeneca. And I am happy to take any questions. And for these questions, my supervisor, Jane, is also joining me. So feel free to get as technical and as geeky as you would like with the questions, because we're here to try and answer everything that you have about this research. So thank you very much.
Thank you, Heather. I remind everyone you can enter questions in the Q&A panel on your screen by clicking the Q&A button at the bottom of your screen. So I do have a question here, Heather. Have you tried some of these techniques in other study populations?
So we haven't used it too far from the MASLD populations. We have looked at cirrhosis in general. So the liver cirrhosis can come about from metabolic dysfunction-associated steatotic liver disease, but it can also come about from alcoholic liver disease as well as other liver diseases. So we've looked at a broader population where it's patients with that most severe form of liver scarring, cirrhosis, but from multiple different causes. And again, EGFR7 is showing promise in there. So we feel that it's got the association potentially with that scarring in the liver fibrosis.
Okay, and how would you imagine that this approach would change if you are testing interventions? And have you assessed any of the existing interventions for their effect on critical elements identified in the modeling?
So we haven't currently assessed interventions for this sort of analysis. Random forests can be used for predicting of treatment responders and non-responders, for example. If you have clinical trial output data where you know if patients are responders or non-responders, you can use a similar analysis where you try to classify patients as responders or non-responders from their data. And then obviously, before you run your next trial, you can then make a prediction on patients recruited, whether you think they will be responders or non-responders. So that's sort of the best use case I can think of that could be used in sort of a clinical trial sort of situation where you're looking for treatment effect.
Okay, and have the critical elements identified for the pathophysiology in this indication, have you looked at those in other indications related to the metabolic dysfunction-associated liver disease? So for example, alcoholic liver disease or other types of dyslipidemia?
No, so we haven't looked in other types of liver diseases. As I said, the sort of broadest thing we've done is in that cirrhosis cohort that we've looked at. So a broad range of indications that lead to liver scarring.
And I think, just to add on with the fibrosis, that's, as you were already alluding to, right? So the liver scarring or the fibrosis is the key here. So we actually are curious to see whether or not this particular biomarker that we found now is also related to other types of fibrosis. So for example, heart fibrosis or kidney fibrosis. So that is something that will be ongoing work now as a next step.
Thank you. Have you looked into integrating this type of modeling approach with other types of models that could give insight into causality and the network connections? So it seems like you're teasing out elements that are important. What can you do to help understand how they affect other components of the network mechanistically?
Yeah, so currently I haven't necessarily looked into how this feeds into other parts of the network. But what we would be keen to look into is whether it can be used as a potential endpoint biomarker. So that's something that we would certainly want to look into is how that's affecting disease progression. so that we can establish whether this can be used as some sort of endpoint surrogate in clinical trials, or whether it can be used in screening procedures. But we would like to tease out more about how it is associated with disease progression, but that is not something that we have currently done.
But I think this question has come up before, so it is a very good question, and we have also had these discussions before when we look at the full range of biomarkers that come out of the random forest, and how are we better understanding the disease with the full range of them. So that's also work that's going to be ongoing, I'd say. So because as you're alluding to, so how do they correlate? How is the causality between these? So that's something we also discussed. But now that we found this one that is really predictive, it's kind of, it's almost like a low-hanging fruit. We all kind of are jumping on that and kind of follow that train. Because that, I mean, if that comes out and we can validate it in further cohorts, that literally changes patient like care. It's like it's a huge thing. We've been looking for such a biomarker for a long time in this disease field. So there's been multiple kind of consortia ongoing to try to find that. So if this is really something that we can again and again show, it would be great for the patients.
Yeah. Oh yeah, I agree. So I had a practical question. Basically the big picture question is, how long did it take to develop this model starting from scratch? And I recognize you have other work responsibilities during the day, but how long does it take to typically do this type of analysis on a new indication, let's say?
So that was really quite the nice thing about putting the time into developing this as a full pipeline. So now that it's been developed, which was a good 12 to 18 months of my postdoc has been sort of dedicated to this. There has been other stuff, but this has been a big focus. But now the pipeline is developed, it can be quite rapidly deployed to new data sets as and when they come in. Really, you just need a data set that is big enough. And I would say the data set we developed this with was about as small as you want to go. But any sort of data set where you have a large number of biomarkers, a decent number of patients, and you have some sort of categorical indication that you're trying to predict, you can rerun this pipeline from the start in a few hours, not including data cleaning and preparation on all of that once you've done all of that. But you can run this pipeline and start getting some initial results out quite rapidly.
Great, thank you. Has this work been published yet or presented publicly? And
so this was, sorry.
No, go ahead.
I was going to say, this was presented at the Population Approach Group Europe conference that was held in Rome this summer. And that was the first place this was fully presented as a poster. And we are currently working on getting it published.
Great.
So this is a key piece, right? Because this is such an interdisciplinary kind of work. I think it makes a lot of sense to have it like in this community, in the pharmacometrics community, so to say, or in the modeling community. But it also is a very highly clinically relevant kind of question and like that answer, so to say. So we're like have tried to assess where it fits best now, and we're probably going for a clinical focus next. So really changing patient care. So that's kind of where we're going now. Yeah.
Yes, and certainly the audience is interested in trying some of these techniques and is just looking for a resource to get started. So maybe we can put you in touch with some of the participants if they'd like the citation when it comes out.
Yeah, no, definitely. That would be great.
Great. Okay, next question. With respect to your random forest algorithm, can it be applied to identifying a combination of biomarkers rather than a single one?
Yes, absolutely. So I'm just going to jump back some slides. So if I jump back to this slide here, so on the left-hand side here, all of these features that you're seeing here came out as important. So the maximum shadow variable that I was talking about, the one whose importance came about by random chance, is shown here. And we had these few that couldn't be classified in the full number of iterations that we retained just to be cautious. But this selection of biomarkers here absolutely could be used to draw out a combination of biomarkers of interest. So you could imagine another cutoff point we could have looked at, perhaps, just looking intuitively here, is our top 4 could have been of interest to us. And actually, we have done some analysis on our second ranked biomarker, looking at no fibrosis versus any stage fibrosis. And this was coming out as significant in that. So there's clearly some key assessments that could be made around these top 4. You could look at the broader, a full collection and do some analysis across all of them. But absolutely, and particularly if you're working with like a genomics data set, they could be brought about looking into like some sort of genomic signature. That's absolutely something that random forests and feature importance are used to assess.
And do you maybe want to also comment on, like, because we know you just show EGFR7 and FIP4, but we also did just how well the random forest.
Yes, yeah, that's true. So also you can assess these same metrics on the right-hand side for the full random forest. So that is, if you have all of these biomarkers again for every patient you get, you can just run them through the random forest again. And so again, that leaves no patients unclassified because the random forest has no threshold. So it's looking at classification for all patients. And the sort of model metrics here were higher than both of these, as you would expect, because you're performing the classification with significantly larger number of biomarkers. In our analysis, the reason we didn't look at just retaining the random forest as a whole is that the majority of these biomarkers that are being highlighted as important are from the Olink proteomic platform, which is quite an expensive platform and unlikely to be routinely used in clinical care. But if you were looking at a data set of just standardly collected clinical biomarkers, you absolutely could just retain the whole random forest for your sort of classification.
Oh, interesting. And subsets of that too. For example, if you wanted to pick 3 to be a powerful combination of predictors when used together, you could do that as well. Yeah.
So as I said, like for us, you could look here. Another thing to do is recalling that we were selecting the all relevant data set. If you wanted to power your prediction more, you might look for the minimal optimal data set. So you might use a different feature importance algorithm than us. So you don't have to use this Baruta feature selection we did. You could use a different feature importance algorithm, in which case you would have biomarkers that have no correlation. And so then they can be, combinations of them can be highly predictive for different outcomes.
Great, thank you so much. Well, that's the questions for today. So thank you, Heather. We really enjoyed your presentation. I'd like to remind the audience that the next webinar will be in December. We're taking a break for November because we're going to the ACOP conference. So hope to see some of you there. And thank you for joining. Goodbye, and we'll see you next time.
Thank you, everyone.
Thank you.
Thank you.